Welcome to Science News. I'm Mark Creager, President of the American Heart Association, and with me are two past presidents of the American Heart Association, Drs. Bob Bonow and Elliott Antman. And we're in London at the European Society of Cardiology Congress. And today we heard several very interesting trials at two Hotline sessions, Hotline 1 and Hotline 2. Now, Hotline 1 had several trials that dealt with left ventricular remodeling. One looked at diagnostic tests to evaluate left ventricular remodeling and see how well they predicted, and several others looked at different interventions. Bob, share with us some of your insights from Hotline 1.
You know, trials are important because they give us new insights as to where the field is going, but also sometimes give us negative results. So we have at least tested the hypothesis, and now we've come away with some new understanding, but we need to go in other directions. One of the more important studies was called the DOPPLER-CIP, which is obviously an abbreviation which had nothing to do with Doppler per se. It had to do with imaging. I guess Doppler was part of that, but the gist of it was to identify patients who had chronic coronary disease, to identify who may be showing progressive enlargement of the left ventricle, which based upon studies with acute coronary syndromes has been shown to be a really bad thing to happen, where you get adverse remodeling and heart failure. They found that MRI actually was the best way of measuring the ventricle, which was not a surprise. They found that patients who had prior infarctions had the tendency for more remodeling, which is also not a surprise. But this was the first time when the remodeling concept had been applied to people with chronic disease. And they did show that indeed these patients were showing progressive remodeling. And one of the points they made was that even small ventricles were showing progressive remodeling. My concern about the study, and this is hot new data, and the investigators clearly will analyze it further, but you know, they had a heterogeneous population. Some patients had prior MI, some patients had prior revascularization, some patients had some degree of mitral regurgitation, which can also cause remodeling. So I think we need to let the dust settle a little bit. It's not clear exactly what the medical therapy was. Hopefully all patients were getting ACE inhibitors and beta blockers if they had evidence of LV dysfunction. And we don't know even some of the other characteristics, like who had high blood pressure, who was still smoking, or other things which might impair ventricular function over the course of time. And there were no endpoints as to who developed heart failure, who died. It did show, though, that imaging could be quite important, and that's kind of the basis for perhaps the other two studies we could talk about. There was a study called CIRCUS, which was a trial looking at cyclosporin as a intervention in patients with large myocardial infarction with the attempt to block some of the reperfusion injury that occurs. A lot of the remodeling is not just the initial damage to the heart, but the ultimate infarct size could be related to the amount of reperfusion injury. And so cyclosporin is obviously used a lot for cardiac transplantation, but also has been shown to be a biochemical that will block the permeability pore of the mitochondria, which is where the calcium leak occurs when you've got oxidative stress. And so this was an attempt to block that mechanism, and in doing so they had negative results. It did not change the composite endpoint, which was death, heart failure, or left ventricular remodeling. So it was an important study, another one in a series of studies that have been done over the last couple of years trying to block reperfusion injury. And I think we're still looking for the solution to that. Probably the best solution to that is to intervene early, you know, so that we're doing early. Early
time the reperfusion.
Time is everything here. And then the final one to talk about was a study called ALBATROSS, which was again an abbreviation of a lot of words, which was looking at aldosterone blockade in patients with myocardial infarction. It's based upon the Ephesus trial, an earlier study using eplerenone, showing that in patients who had heart failure after myocardial infarction, adding aldosterone to ACE inhibitors and beta blockers led to a better outcome. Here the hypothesis was, based upon Ephesus, which showed that early intervention was better than later intervention, that really, in this case, early intervention within 72 hours of an acute myocardial infarction might prevent some bad outcomes, a composite endpoint again of death, ventricular tachycardia, need for ICDs, heart failure, et cetera. So in that composite endpoint, they found that aldosterone blockade, in this case using spironolactone, 25 milligrams a day, did not lead to a better outcome, either with the composite endpoint or any of the individual endpoints within that composite. Unclear exactly what that might mean because it was a single dose of 25 milligrams, perhaps a different dose or maybe a different agent might be beneficial. We don't know that for sure. They did see a signal in patients who had ST segment elevation MI that perhaps this might be beneficial, more so than patients with non-STEMI, and that I think makes sense physiologically. These are probably the patients with a worse heart attacks and perhaps more myocardial damage. But it was negative, and so we have another series of negative trials. But you know, one takeaway, Mark, Elliott, is that there are actually 4 acute MI studies in that hotline session. Almost 50% of the patients were smokers. You know, and so I think a take-home message that I think is important is that we still do a better job of preventing the heart attack in the first place, and we're not dealing with the damage and the downstream effects of trying.
Emphasizing a culture of health.
There we go. I think that's quite important. So that was Hotline 1. It was a good discussion, but not a lot of new positive information.
You know, Bob, I was thinking as you were discussing the chronic remodeling situation, you know, many patients are placed on medications that we start to prevent remodeling, and they're feeling fine a year or two later, and they may ask, do I still need to take these medicines? This would suggest that they do, because there's a longer-term remodeling concern that we have, and that's quite interesting.
That's true. I mean, they excluded patients who had the MI within 3 months. So these are patients who were well out, if they had an MI, well out, and some of them had never had an MI. And so I think these drugs are important.
Yes.
And hopefully they will actually give us the data as they do more analysis to tell us whether the medication regimen was in any way helpful preventing the remodeling.
So several important messages. One,
absolutely.
We have tools to prevent coronary disease, myocardial infarction, smoking cessation. Let's use them. We do have therapies that are effective already in reducing the risk of remodeling and its extent.
That's early reperfusion.
Absolutely.
Time is everything.
But negative trials are also important. They inform us, we learn from them, and then we move on to test additional hypotheses, and hopefully, as we keep doing that, we will find interventions that will be effective.
Negative trials are important because they do inform us.